Now we will start the presidential lecture. The moderator is Professor Masao Omata. Professor Omata, please start when you're ready.
Yes, it's really a great pleasure and an honor to invite Professor Shina as the president of the 33rd annual meeting of APASL. As shown that we worked together almost 17 years. And then since we are apart, in a sense, he went to the Juntendo hospitals. And the amazing thing is that he is doing his treatment for hepatocellular carcinoma continuously. So if he is not the president here, maybe he is doing the same treatment now in Juntendo Hospital. But anyhow, he graduated University of Tokyo, then joined the second department of medicine at the University of Tokyo, and then he started his treatment at the Mitsui Kinen Hospital. And then that time, Chiba University also started ethanol injection therapy. So he learned how to do it in Mitsui, then went back to the department, second department. And he is moving, after he's moving Juntendo hospitals, he continued. And maybe he talk about how much he has done it and what kind of the new ideas, new technology in the area of the hepatocellular carcinoma treatment. So I've been looking forward to listen to his talk in this morning. So Dr. Shina, President of the 33rd annual meeting, please.
Thank you, Professor Omata, for kind introduction. So today I'd like to talk about ablation for liver tumors. So since I graduated from the University of Tokyo, I've been engaged in percutaneous image-guided ablations. And so at the first time, ethanol injection, then first generation microwave ablation, then radiofrequency, and now new generation microwave ablation. So this slide shows the geographical distribution of hepatocellular carcinoma. The Asian Pacific region is a highly endemic area of the HCC. And the lower part of the slide shows the geographic distribution of HBV and HCV. Highly endemic areas of viral hepatitis overlap with those of HCC. And ablation encompasses ethanol injection, radiofrequency ablation, microwave ablation, and others. Ablation is potentially curative, minimally invasive, and easily repeatable for recurrence. And Japan is the birthplace of ablation such as percutaneous ethanol injection and microwave ablation. So in Japan, radiofrequency ablation was first introduced in 1999. Radiofrequency ablation has been the most widely used ablation techniques for liver tumors. And this is our second case of radiofrequency ablation. This is a 48-year man who was found to have a tumor 3.6 centimeter adjacent to infravena cava in February 1999. So that means 25 years ago. And this is a CT scan taken after a day, which demonstrates the entire tumor ablation. Some doctors may say that radiofrequency ablation cannot ablate tumors adjacent to large vessels entirely because of the heat sink effect. However, this is our second case in which we performed radiofrequency ablation 25 years ago. This case clearly shows that radiofrequency ablation can ablate them if it is performed skillfully. And this is our early study, from our early study, so, and showing the anti-tumor effect of RFA. So complete ablation was achieved 99.4%, that is 5,424 out of 5,457 of the treatment. And regarding the long-term outcomes, this slide shows the survival of 1,616 patients who underwent radiofrequency ablation for primary HCC. 5-year survival rate was 62%, 10 years 28%, 15 years 15%. And now, a new generation microwave ablation system incorporating antenna cooling and high power generation have attracted attention. I would like to show you a demonstrable case. This is an 80-year-old man who was found to have a tumor of 4 centimeters in diameter beneath the diaphragm. We use the artificial ascites techniques and we performed microwave ablation. And a CT scan a day after ablation showed the entire tumor necrosis. And this slide shows the number of cases treated with radiofrequency ablation and microwave ablation at our institution. We have performed more microwave ablation than radiofrequency ablation recently. Accumulated number of microwave ablation cases by December 2023 is 1,929. Many high-volume centers of ablation in Japan have introduced new generation microwave ablation for liver tumors. And I would like to talk about competition with surgeons. Since the ethanol injection period, we have had strong argument regarding which treatment is superior for HCC, surgical resection or percutaneous ablation. And so in Japan, we conducted a multi-center randomized controlled trial called SURF trial to compare directly surgery with radiofrequency ablation. 49 major centers in Japan enrolled patients with good hepatic function and HCC of 3 or fewer nodules, or 3 centimeters less in diameter during the 6-year period of 2009 to 2015. And a total of 308 registered patients were followed for at least 5 years. And this is the overall, this slide shows the overall survival and recurrence-free survival of surgery and radiofrequency ablation. The final result of the SURF trial was announced in 2021. It revealed that overall survival and recurrence-free survival were not different between surgery and radiofrequency ablation in HCC of 3 or fewer nodules, each 3 centimeters or less in diameter. And this is the previous Japanese treatment algorithm. In this algorithm, resection was placed above RFA, indicating that resection should be a priority. However, as a result of SURF trial and other comparative studies, the revised algorithm in 2021 treat hepatic resection and ablation equally for patients with HCC who have 3 or fewer tumors, all 3 centimeters or less in diameter. And this slide shows a comparison of scars between surgical resection and ablation. Ablation is a minimally invasive therapy which does not require general anesthesia or laparotomy. Ablation is performed on patients with liver cirrhosis or advanced age safely. And now I'd like to talk about the combination of pharmacotherapy and ablation. This is a treatment algorithm for hepatocellular carcinoma by Apasul 2017. So ablation is used for early HCC as a potentially curative treatment but ablation cannot be indicated for advanced HCC. On the other hand, pharmacotherapy is used for advanced HCC, which cannot be treated by either surgery or ablation. And we think the combination of ablation and pharmacotherapy may build a new treatment strategy. I would like to show a demonstrable case. This is a 72-year-old man with taste refractory HCC treated with lenvatinib and ablation. He underwent hepatectomy 2015, and next year he developed recurrence and he underwent TACE. And then even after that, he repeated recurrence and underwent TACE. And after 6 times of TACE, he was judged refractory to TACE. So he was referred to us and we introduced lenvatinib. This figure shows the HCC condition when he was referred to us and we started the lenvatinib. The largest lesion, 7 centimeters in diameter, was adjacent to infravena cava. And the second tumor is 31 millimeter in diameter in segment 8. The third tumor on the surface, and fourth tumor in also segment 8, and this tumor near the surface of the liver with lipidol deposit. And the sixth tumor is in segment 5 to 6. And after 12 weeks of lenvatinib, the largest tumor lost vascularity, as shown on this slide, and shrunken from 70 millimeters to 56 millimeters. However, hypervascularity remained in 3, 2 enlarged, and the other unchanged. So we decided to perform microwave ablation for the 3 tumors, and 3 months later, we performed second microwave ablation for 2 other tumors because contrast-enhanced ultrasound detected vascularity in them. And we stopped the lenvatinib 2 months after second ablation. For more than 3 years, he has not received any treatment for HCC, not either pharmacotherapy or ablation. So far, we have had 36 cases in which the combination of pharmacotherapy and ablation has achieved complete response. So combination of pharmacotherapy and ablation may build a new treatment strategy. And I'd like to talk about artificial intelligence and other technologies will further improve outcomes in ablation. Artificial intelligence is said to have the potential to assist ablation in terms of modeling, planning, monitoring, and evaluation. I am hopeful that in the near future, artificial intelligence will play a role in assessing whether a tumor has been completely ablated or not. And artificial intelligence has the potential to offload the time-consuming process of comparing pre- and post-ablation images. In the very near future, they can do that. Incidentally, ablation has some problems. Ablation appears a relatively simple procedure. Thus, some doctors may perform ablation without sufficient training. And ablation is possible to be performed even with inexpensive, poorly performing equipment. Thus, ablation may be performed under inappropriate circumstances in some institutions. In order to raise the level of ablation as a whole, we have held ablation training programs. Programs are composed of comprehensive lectures, live demonstrations, and case studies. First, I would like to introduce a study of comparison of ablation outcomes between the beginner and who received training at the high volume center and the self-training 800 case experienced doctors. One doctor, the beginner, is a board certificate gastroenterologist who had no experience in ablation procedures. He received training for 6 months, however, at a high volume center before starting ablation at his own hospital. The other one, the experienced, had performed more than 800 cases of RFA in the past 12 years, but was principally self-trained. And this is a comparison between the beginner and the experienced. The beginners performed 43 cases. On the other hand, experienced performed 49 cases. The background were not different between the two groups, but mean operation time was 75 minutes in beginners, while it was 49 minutes in the experienced. So beginners had a significantly longer procedure time. However, on the other hand, the beginner who got a 6 months training at a high volume center used various techniques like the pleural effusion techniques and peritoneal effusion techniques. And regarding the residual region, impossible region to ablate or local recurrence ratio, there is no differences between the two groups. However, this is our overall survivors, comparison of overall survivors between the beginners who received 6 months training and the expert, self-trained expert. And the 5-year survival rate was significantly different between the two groups. So the 8-year follow-up study showed that the 6 months training at a high volume center resulted in the better outcome than the self-trained of over 100 cases in RFA. So that's why we started the ablation training program. And this slide shows the trend in national ranking of top 10 hospitals in Japan for liver tumor ablation. So Tokyo University, the University of Tokyo, was the largest number of ablation cases until 2012. But however, since the 2013, Juntendo University had the largest number of ablation cases in Japan. And this is from Nikkei Shimbun newspapers article. Nikkei Shimbun articles show that Juntendo ranks first in Japan for the liver cancer survival rate. It has been confirmed that so Juntendo University's liver cancer treatment ranks first, not only in the number of patients, but also in treatment result. Okay, that's why we now have the training programs at Juntendo. And our training programs consist of the lectures. The context of the lectures include current status of ablation devices, ultrasonography, and others. And regarding the live demonstration, we perform RFA or microwave ablation on 3 to 4 cases per half day using artificial ascites technique, artificial pleural effusion technique, contrast-enhanced ultrasound guidance, and fusion imaging method. In the 5-day program, you'll be able to see 12 to 15 cases of live demonstrations. In case studies, difficult to ablation cases from participant hospitals are presented and discussed. This slide shows a total of 237 participants in the 1st to 14th domestic ablation training programs. And we also have the international ones. This slide shows 111 participants in the first to 7th international ablation training programs. And however, during the pandemic of COVID-19, we were not able to hold on-site training programs. To overcome the situation, we held domestic international ablation webinars. And regarding the domestic one, so from the first to 8th webinar, we have had the 1,566 participants. And regarding the international ones, 1,278 participants in the first to 4th international ablation webinars. After the COVID-19 pandemic, we have resumed both domestic and international ablation training programs. We plan to conduct the programs 3 or 4 times in the latter half of this year. And we accept both domestic and international fellows. Here are the overseas fellows currently undergoing training or scheduled to train this year. And we established Japan Academy of Tumor Ablation, JATA, in 2022. There are some triggers. The first is the announcement of the results of SURF trial and the following revision of the treatment algorithm gave an impetus to the establishment of JATA. And the second, Asian Conference on Tumor Ablation, ACTA 2021 in Tokyo also served as an impetus for the establishment. And the third, expanded insurance coverage for ablation is the third impetus. So, as a result of the multi-center randomized controlled trial in Japan, SURF trial, and others, the recent treatment algorithm treats hepatic resection and ablation equally for patients with HCC of 3 or fewer tumors, each 3 centimeters or less in diameter. And compared with surgery, ablation is significantly less invasive, making it a promising option, particularly in an aging society where invasiveness matters. The indication of ablation are expected to broaden in the future. Microwave ablation can create a more predictable, larger ablation area in a shorter procedure time. And the combination of pharmacotherapy and ablation may build a new treatment strategy for advanced HCC. Cure can be achieved in selected advanced HCC. And artificial intelligence and other technologies will further improve outcomes in ablation. And education initiatives are crucial in ablation to disseminate skills, standardize procedures, and share knowledge. We offer both domestic and international ablation training programs, and we welcome both domestic and international fellows. And we established the Japan Academy of Tumor Ablation, JATA. Thank you very much.
Yes, thank you very much. The lifetime achievement of these ablations, I think he continues this method. And especially if you combine the systemic therapies, I think the expansion of the treatment is enormous. So I hope that you go into the things both for the patient's sake and the education. Thank you very much. I will finish my presidential lecture. Thank you very much.
Thank you very much, Professor Shina and Professor Omata.